Systemic lupus erythematosus is a chronic inflammatory disease that has versatile manifestations. It can affect almost any organ system, but it mainly involves the skin, joints, kidneys, blood cells, and nervous system. It is characterized by widespread microvascular inflammation and the development of autoantibodies, including anti-nuclear antibodies and antibodies to the double-strand DNA. More than 90% of cases of SLE occur in women, frequently starting at childbearing age. The classic triad of fever, joint pain, and rash in this population should prompt investigation for SLE. The diagnosis of SLE involves a thorough history, physical examination, lab tests, and serological testing which are specific to SLE. The American College of Rheumatology has developed criteria to classify patients with a diagnosis of SLE. SLE is suspected if 4 of 17 criteria, including at least 1 of 11 clinical criteria and 1 of 6 immunological criteria, are present. Management of SLE often depends on the individual patient's disease severity and disease manifestations. Conventional therapy may include NSAIDs, glucocorticoids, hydroxychloroquine, and immunosuppressive agents. A few alternative nutritional therapies we choose to highlight are vitamin B6, vitamin D, and fish oil. A prospective observational study of 231 Japanese women with inactive SLE were followed for over 4 years. The research found inverse correlation between vitamin C intake via food and risk for developing active disease. Furthermore, dietary vitamin B6 was inversely associated with risk for active disease. These studies concluded that a diet high in antioxidants, especially in vitamin C and B6, may benefit SLE patients. We believe it is important to check dietary intake of vitamin B6 and supplement if necessary to achieve 1,500 milligrams per day. Vitamin D is a corticosteroid hormone produced in the skin in response to UVB radiation from the sun. It has various regulatory and functional effects on the body, such as regulating cell growth and maturation, inhibiting renin production, stimulating insulin secretion, and modulating innate and adaptive immunity. The major circulating metabolite of vitamin D is 25-hydroxyvitamin D, and is used as the indicator of vitamin D status and reflects levels from dietary intake and synthesis in the skin. Vitamin D receptors are found on immune cells and are shown to shift T cell activity into the anti-inflammatory state. It is believed that overproduction of various cytokines that shift the balance of Th1 cytokine secretion towards Th2 cytokines contribute to increased disease activity. Furthermore, these cytokines mediate B-cell hyperactivity, which promote plasma cell differentiation and antibody production, leading to autoantibody formation. Numerous observational studies have shown links between vitamin D status and disease activity. 2 RCTs compared the effects of vitamin D supplementation on disease activity. The first study showed that supplementation of 2,000 IUs per day for 12 months improved levels of inflammation in treatment versus control, and that lower 25-hydroxy-D levels correlated significantly with higher disease states. The second RCT supplemented 50,000 IUs per week for 24 weeks of vitamin D. At the end of the intervention, a significant improvement in disease activity was reported in vitamin D group versus placebo. Evidence for supplementing vitamin D for fatigue is mixed. There are a few studies with positive results on the reduction of fatigue related to a social life score in treatment versus placebo. From our research, we found that studies on vitamin D supplementation for fatigue is weak and limited. A holistic approach incorporating exercise, diet, and acupuncture may have a greater impact on fatigue than monotherapy with vitamin D. A study that looked at cardiovascular disease risk in SLE women found that lower 25-hydroxyvitamin D levels were significantly associated with higher diastolic blood pressure, low-density lipoprotein cholesterol, lipoprotein A, body mass index, and other markers of cardiovascular disease risk. However, they also noted that when adjusted for BMI, the association between vitamin D and CVD risk was not significant, suggesting weight may be a better predictor of CVD risk in SLE. Although vitamin D insufficiency and deficiency observed among the general population of Canada, an increased prevalence is reported in the lupus cohort. This has been linked to a predisposing factor to onset disease of itself, perpetuating autoimmunity, and the consequence of the disease itself. For this reason, we feel all SLE patients should be supplemented daily to reach 40 nanograms per ml. According to research, we recommend a dose close to 7,500 IUs a day. Fish oil is a source of omega-3s EPA and DHA, which have anti-inflammatory effects. In 3 double-blind RCTs, fish oil was significantly more effective than placebo for improving clinical outcomes in patients with SLE. In all of the double-blind trials, both positive and negative, the placebo was olive oil, which itself has anti-inflammatory activity. Therefore, the benefit of fish oil may have been more pronounced if a different placebo had been used. In the management of SLE, dietary supplementation with omega-3 fish oils in SLE not only has therapeutic effect on disease activity, but also improves endothelial function and reduces oxidative stress, and may therefore confer cardiovascular benefits. For this reason, we believe supplementing with 1 to 3 grams per day of fish oil to be a good starting point for adjunctive care of SLE. Other therapies that a well-rounded clinician may also consider include dietary modifications, flaxseed supplementation, turmeric supplementation, indole 3-carbinol supplementation, copper supplementation, DHEA therapy, and/or testosterone therapy.